Show up a little late this morning. So everybody here understands that.
That's more important.
All right, so we will go ahead and call to order the Quality and Patient Safety Committee meeting on Thursday, October 23rd. We'll gavel. All right, so first on the agenda is just citizens.
We don't have any.
We do not have any citizens today who are going to address the committee. And I would like to make ask for a motion to approve the minutes from the last quality meeting, which was July 24th. He has reviewed that.
So
Can I get a second?
I'll second.
Thank you. So we can motion and second to approve is that correct?
Yes.
But,
All in favor?
All in favor? Any opposed? Thank you. All right, moving on. I lost my place here.
We are at,
Okay, Dr. Badamos, he's going to start with patient voice.
Good afternoon, Dr. Holland. Good afternoon, everyone. Today, our patient voice, as usual, will actually, it's an excellent patient video that will introduce to us the program we're about to discuss. And it really illustrates the patient impact of a lot of the programs that were run here at JPS. And it's about the OPAD program, but I will let the video speak for itself.
That's my three kids. It's my grandpa was a tank commander in World War II, 55, I believe it is. How much it cost to fill the car up, get a quart of oil. Can't even buy a quart of oil for that now. Ronald Reagan, Theodore Roosevelt, Ford, Nixon, and Lincoln playing cards. I like Indian motorcycles, Cadillac cars, Marilyn Monroe, and I work for an estate sale company, which helps with my habit. Like I said, a lot of the stuff you can't see because it's covered up with more crap or valuable merchandise. My name is Dale L. in Denmark, and I was in JPS right before my 54th birthday. As far as I'm concerned, they're the reason why I'm alive today.
He's been with us since March of 2022. He's been through 5 rounds of IV antibiotics. He has history of diabetes and peripheral vascular disease that puts him at risk for bone infections and bloodstream infections. So he's had a left foot infection that led to below-knee amputation initially. He also had a bacterial infection in the blood called MRSA. Initially, we felt after his amputation that he needed to go to a facility because he won't be able to do the antibiotics at home.
To be in a rehab place just for to have a PICC line installed didn't make any sense to me when I could live at home.
OPAT is outpatient parenteral antimicrobial therapy.
OPAT is a program in our infectious disease clinic. And so we have a team that teaches patients how to self-administer IV antibiotics. It's a really neat program that gives patients autonomy. So they are able to get discharged from the hospital and go home and finish their treatment at home.
We decide that this patient needs the IV antibiotics for 2 to 6 weeks, anywhere from that time frame. And then we start screening the patient to see if the patient is a good fit to go home. So they have to have a stable home situation. Transportation to come once a week to our clinic to do some labs and pick up the supplies for the next visit. And they should not have any high-risk behaviors like history of drug use.
Well, I've always been stubborn. You know, I wanted to be able to take care of myself. They gave me a hose that I could reach, put between my pinky and my other finger, where I could give myself the syringe and do that 3 times a day, because I figured I could figure out how to do it before I go to a rehab facility just for that. It would take me a while, but I could do it, and I didn't have to, go through the expense for whoever was paying the bill of going to a rehab facility, and I could be at home, cook my own meals. That's what I like to do. The biggest thing about all this is I can't crack an egg with one hand like I used to and not break the yolk.
One of the big wins on the patient end is that it gives them autonomy and independence so they can go back and do continue their day-to-day life, whether that's going back to work or going back to enjoying their family if they're retired, going back to their hobbies.
With home health, they have to pay out of pocket for some of the services. So this program essentially is free now for JPS connection and self-pay patients. So they love the program. A lot of them want to work. They want to have some independence at home. So we have seen that the patient experience has been very good.
58% of patients let us know that they were able to go back to work, which is huge for them and for their families. In addition to that, 100% of patients let us know that they preferred OPAT over SNF or home health.
They all seem to genuinely care about their patients, because I know there's a lot of people in there that have ailments way worse than me, and they actually listen to what your concerns, your questions, and they give you good answers. They said they've had people that tell them that they can't give themselves IV antibiotics at home. And I say, BS. If I can do it with these hands, somebody with normal working hands can do it.
That's really a great video that actually speaks to the patient impact of this program. Dr. Holland, it's my pleasure to actually welcome the team members to actually do this work. The medical director of the OPAT program, Dr. Narasimhan, as well as Selenia Garcia, the outpatient director of specialty clinics. Dr. Narasimhan, Selenia.
Welcome.
Welcome.
Good afternoon. Thank you so much for having us. We're really excited to be here.
Thank you for having us.
Yes.
That's my
Okay, so we are going to be presenting on OPAT today. As the video told us, OPAT stands for Outpatient Parenteral Antimicrobial Therapy, which is a mouthful, so that's why we say OPAT for short. So a little bit of background about antibiotic use is
Would you tell us, I'm sorry, would you tell us a little bit about yourself?
Absolutely, I would love to. My name is Selena Garcia. I am a director in community health and have responsibility over the medicine specialty clinics, which includes the OPAT program. I was actually born at JPS, so I'm a Fort Worth native, and I'm absolutely thrilled to work for such a wonderful organization. And I also had the privilege of working with Dr. Holland at my previous organization when she came out of residency out of JPS. And so now our worlds have crossed again here. So it's truly an honor.
Thank you.
Yeah.
I'm Dr. Narasimhan. I'm an infectious disease physician here at JPS. I'm the medical director of the program, and I oversee the program. And this December will be 8 years at JPS, so it's been an honor.
Thank you.
Okay. So a little bit of background about antibiotic use is nationally 55% of our patients receive IV antibiotics. The average intravenous antibiotic course lasts anywhere from 10 to 14 days. And some of the most common infections that require prolonged IV antibiotics are osteomyelitis, endocarditis, prosthetic joint infections, bacteremia, multi-drug resistant bacterial infections. And usually patients become clinically stable after 7 days, but they may need ongoing treatment for 4 to 6 weeks. So what OPAT does is it enables patients to complete at least 2 doses of IV antibiotics 2 separate days safely outside of the hospital. And there is 2 types of OPAT. There is self-administered OPAT, which is patient or caregiver administered. And there's HOPAT, which is healthcare administered, and that is delivered at infusion centers, skilled nursing, or at home with home health services. So what we have here at JPS is SOPAT, which is self-administered by the patient or their caregiver. And we launched this program April 6, 2021. We do have criteria in order for patients to be eligible for OPAT. They do have to have JPS Connect or self-pay. They have to have a stable and safe living situation because they are handling meds medications and administration. We want to make sure they have access to running water, refrigeration, etc. They do have to have reliable transportation. We do ask patients to attend weekly clinic visits with our nurse, and so we have to make sure that they are able to get here. And they also have to have the ability and willingness to learn, or have a caregiver that's willing to learn the self-administration process. And our last criteria is no history of IV drug use. Now, we do make exceptions for that. We partner closely with behavioral health, who has their own assessment. So, for example, if a patient has a big gap with drug history, then that could be a patient that we make an exception for, but behavioral health does follow them closely throughout the course of their treatment. So how OPAT is performed is our screening process, which again, the patients have to have a funding status of JPS Connect or be self-pay. And they have to meet the criteria that we went over on the previous slide. And then if they're eligible, they're enrolled in OPAT. And then we do the teaching. So we have a team of RNs that teach patients how to self-administer or teach their caregivers how to administer to the patient. And so it usually consists of 1 to 2 teachings with a teach back to ensure that patient is comprehending the administration process. For the follow-up piece, they're given several resources. They're given our OPAT phone number for any questions that they may have. They are given the QR code for our OPAT administration video. So that's actually given to them during the screening process, so they can already start getting an understanding of what the self-administration process will look like. And of course, they have access to that same video whenever they get home. They're also given a folder with step-by-step instructions for the medication administration process that they can reference. And we also have weekly follow-ups with our nurse. So during the weekly follow-ups, we can do lab work, we can do dressing changes, we assess for any medication complications or side effects. Some of the OPAT benefits is it decreases length of stay in hospitals and saves hospital beds, so the patient does not have to stay here admitted to finish their treatment.
Testing overhead paging system. Testing overhead paging system. Testing overhead paging system.
It also eliminates the need for home health services and skilled nursing facilities, which means that JPS is not having to pay a third party to take these JPS Connect and self-pay patients, which saves the organization dollars there. There's also better monitoring for side effects because they're coming to see us every week. Our nurse follows those patients very closely and talks to us about any challenges or complications that may arise. And our team has a constant eye on the patients that we're following through the program. Because of the close relationships that we have with our patients, it minimizes visits to the emergency room as well. And the most exciting benefit is that it gives patients autonomy to do whatever it is that they love to do. So they can go back to work, go back to their retirement, enjoying their families, which therefore improves the patient experience here at JPS. Now I'm going to hand it over to Dr. Narasimhan to talk about our outcome measures.
Yeah, so earlier this year, we developed a dashboard through which we were able to track metrics and keep an eye on the number of patients and how we are doing overall about the program. And I'm going to go over all the metrics that we studied. So we track the number of patients in our program, and the similar group is a home health group of patients that use home health services, and they are the most similar to our group. So we compare, and those are the services that we provide. So we've been tracking them along with our group. And as you can see, since the onset of the program, last year we doubled our volume from 112 to 221, and we have more patients than the home health services arm. So we're doing really well. This year we have data until June, and we are almost like 112 patients, and we expect to be equal or even higher than last year. And we want to track this because if we expand our service, then we might take over some of the home health services patients. So we want to keep an eye on the volume. Completion of OPAT treatment is very important because we want to make sure they complete the treatment appropriately. And if they're not completing, we're trying to see how they end up. Like, are they in the hospital for further services? Are they completing the treatment there? So as you can see, the completion rate is 92%. And the rest of the 8% patients didn't complete it outside the hospital because they were in hospital for inpatient stay or in the ED where they finished the treatment. But all of them were able to complete the treatment. So we are comparable to home health services with a good trend upward, slightly higher. So this is our payer breakdown. We are primarily seeing JPS connection patients and self-pay patients. We have taken about 14% of funded patients. Those are patients that came to us through throughput meetings where the home health services were not able to be arranged or there was a delay. So we were able to absorb those patients to minimize the hospital beds and get the patients out early. So that was about 14%. This is very important. After discharge on OPAT services, within 30 days, we are looking at urgent care visits, ED visits, and readmissions. And we manually looked at this data because it's not easily visible on the dashboard. So we picked a year from April 2024 to March 2025 and compared the outcomes from our group compared with home health OPAT. So urgent care visits, very low utilization overall. But in terms of ED visits and readmission rate, we were significantly lower than the home health services. It was about 28% versus 15% for us, and readmissions was also very high. I do want to say a lot of our ED visits and readmissions were because of drug-related side effects, which we were able to catch because they're coming weekly to our visits versus home health services going and tracking them. So a lot of these visits were important for the patient, either source control, they had to come back for surgery, or medication-related adverse effect, which were caught early. We looked at the bed days and cost savings. How many days early are we discharging compared to home health? So we looked at the total days of hospital stay and took the difference between the two groups. As you can see, it's about 2 to 4.4 hospital days on an average of 3 bed days per OPAT patient for the length of the program. We worked with finance and they gave us a number as to average cost per day for a patient. So we were able to use that cost and calculate an estimated cost savings, which is not completely inclusive, but it gives us a ballpark figure of the cost savings, as you can see. So we looked at the inpatient length of stay for both groups, and we had a minimum of 3 days less than the home health group. And that's actually the exact amount it takes to arrange home health services or to find a skilled nursing facility. So that's roughly 2 to 3 days. But there are other cost avoidance. We are avoiding skilled nursing facility placement, all the home health cost, and also inpatient cost, because some patients are not able to go either to home or skilled nursing because of IV drug use or inability to be safely discharged, and they end up staying in the hospital for the entire duration of treatment. So those are all the cost avoidance with our program. We are able to really get out a lot of these patients into our program. There's also improved throughput meetings. We regularly attend the meetings, and like I mentioned, about 14% of funded patients we were able to take and do their home health services when they were not able to get. Also reduced readmissions and fewer ED visits. So the patient experience has been really good. This year we started doing this and tracking all our patient experience, also for us to be able to do better. So about 58% of the patients were able to return to work on OPAT. A lot of home health services, some of them have restrictions on their work. They don't let them go to work. So they really loved here because we let them go back to work and be more independent. Some of the patients in our program, because we have been here for 4 years, initially they went to SNF or used home health services. And when they compared that with our program, on the survey, they said 100% of the patients said it's a better option than staying in the hospital or going to SNF or using home health services. Overall, 96% felt very good. They felt very supported after our calls. So we do have, where they can reach us. If they call us on a Monday to Thursday evenings, we're able to call them back in the morning. Any line difficulty, we're able to assess in the ID clinic. So there was very good patient experience responses. So I want to just summarize the OPAT wins. We had about 2,165 bed days saved and a 2.3 million in cost savings without including a lot of other cost savings, which we are working with finance. Reduced emergency and readmission visits in the 30 days post OPAT visit. Reduce central line related complications. Significantly, a lot of patients who came to the ED were all related to central line. We had less compared to home health. Patient satisfaction has been extremely good. And then we are also doing an offshoot of our program now. When we get an outpatient consultation for IV antibiotics, we are able to place the PICC line outside ED visit and get them set up without those patients having to come to the ED. So we have been doing this for a year. We have had about 14 patients so far enrolled in the outpatient PICC line program, and we want to really expand this down the line. So in terms of opportunities, we are looking to include other payers because currently we are only doing JPS Connection self-pay. We are working with pharmacy and finance to see if we can bill those patients so that we can generate revenue. Also, I'm hoping patients will want to leave early and will choose us rather than choosing home health because they get to go home 3 days or 2 days early. We want to increase the outpatient enrollment. We do have a space now in the hospital where we do PICC lines and give the first dose of antibiotics without having to send patients to ED. And we are trying to support this and increase this enrollment. There's no CLABSI so far, which I'm extremely proud of. We have not had a line infection through our program. We want to sustain the quality and safety by monitoring CLABSIs in our patients. So this is our team. I'm the director. We have a practice manager. Selena is the director of medicine specialty. We have an OPAT pharmacist for our program who helps us with drug dosing. We have 2 RNs, Vanessa and Justin. They're amazing. They're the ones who do the teaching, and they're the front line, I want to say. Taylor is our newest addition. She's the APP. She's able to see follow-up visits on a lot of these patients. So they come at 3 weeks and then again at the end of treatment. She also helps us monitor all the labs. If they go to a skilled nursing, we're able to monitor drug dosing. She helps us quite a bit with that. We have a CMA. She's bilingual. She goes with the nurses and does the interpretation for teaching. She also helps with enrolling patients into our program. That's the end of it, and I'm very thankful for the opportunity to present the program. I can take any questions.
This is an amazing program. Dr. Webb, you probably have patients that have used this. Any comments?
So, I mean, I've been here for a long time now, and it's made drastic changes to getting patients out of the hospital. They used to have to sit here for a long time until home health came. You're right, with the JPS connection, sometimes they had to sit here for 6 weeks. It's very relevant.
Thank you.
What determines whether a patient goes on this program for home health? Is that the patient's choice or their insurance, or how do you make that decision?
Yeah, so all the insurance pays for all the home health services. So currently we are only enrolling JPS connection and self-pay patients. because we're not able to bill for the services, if they are insured, we are not able to take those patients. But we are working with pharmacy and finance to see if we can give them the option of enrolling into our program as well.
So we're looking to see if insurance will pay for this?
Mhm.
Insurance pays for the home health services.
But not for our
What
program.
about our program?
So there's a pharmacy credentialing piece that we need to bill infusion medications. And so that's what we've been having conversations around with pharmacy. And so there is a tentative timeline of early spring 2026, where we will have that credentialing to be able to bill for the medication infusion, the medications for infusion, excuse me.
And then we can capture some of those patients that are going to home healthcare. I guess then it's the patient's choice.
Yes,
At that point, if they've got insurance, they can go either way.
yes.
But right now, if I've got insurance and I want to use the JPS program, I have to pay out of pocket.
I think so, yeah.
Yes.
Might not be
Yes.
paid.
Yeah, we typically don't offer it to insured patients.
Don't offer it right now.
It's not offered.
It's not offered.
Hoping to start offering it to the whole population.
Yes,
Just to bring down our average length of stay.
yes.
Materially,
And generate some revenue.
generate revenue.
Mhm.
But, you know, we're probably still paying for it when they're going to home health. It's just home health is getting paid as well, because y'all are still managing the PIC and the antibiotics and the labs, but you're not getting reimbursed, the home health team is. And it's like cutting out a middleman a little
Yeah.
bit here, because home health only comes out maybe once or twice a week. They're not there every day doing the infusion. The patient's still doing it themselves. They're just coming out to draw the labs and maybe clean the site, things that y'all are capable of doing. The only reason I would say that home health would maybe be superior is if the patient was housebound for whatever reason, could not come into the clinic.
Yes, with our program, they have to come once a week.
Yeah.
But with home health, all the meds are delivered and the nurses go out to their homes to do the labs and do the line changes. So they remove the line also at the end of treatment.
I think this is a superior option to home health, honestly. The only piece that home health offers is that patient who can't get into the clinic for y'all to hands-on, because you're still managing that patient even with home health there. So I think this is fantastic. And you know, what I see when my patients are outpatient and getting the PIC, they're still doing the medicine themselves, even when there's home health involved. So they still need the education from y'all's team. They still need all that handholded support. And so if we could like have y'all oversee it closer than having that home health, because there's always a delay with home health too. So the home health goes and draws the labs and then they, you know, get the lab results eventually, but this is much more real time for y'all. So I think this is wonderful. Anybody else have any questions? Be nice to see if y'all could get the insurers to cover it. Do y'all have capacity? Like, what is your capacity? Could you take on more patients?
We do have some capacity. We originally on the team had a case manager and a nurse. And so what we found is that the case manager was limited to their scope. And so we converted that position to another nurse. And so now they share responsibilities, which expanded our bandwidth. So we do have capacity to take on more patients. And so our thought was when we get the credentialing to be able to bill insured, maybe we start with you know, pick a couple of insurances to start off with, but we are working on some productivity metrics to understand our bandwidth so that we're ready when that time comes.
Thank you.
Thank
Thank
you.
y'all.
Thank you for having us.
Thank you.
Thank you so much.
Yes, thank you, sir.
And y'all got to win when Selena abandoned me and came here. So.
We did.
And it's an
Badamosi's now going to talk about quality.
yes, ma'am. So as usual, the quality priorities identified for 2025 included patient experience in Africa. I'm bringing both of these back to provide an update to the board. With patient experience, we continue to do very well, and we are progressing and still on track. We do have George French and his team, our VP of Patient Experience, helping with this program and working with all of our providers. Month over month, we continue to increase, and this is really having a lot of meaningful impact on our patients. The other program is the Africa program. As you will recall, this is the program, the quality program that accompanies the managed Medicaid program. There are 6 metrics that we follow: the cesarean birth, the post-operative sepsis, readmission, food insecurity, influenza, and safe opioids. We continue to do well with those. It's only the cesarean section that we're working on, as well as the planned all-cause readmission. Again, the way the state defined this metrics really puts a lot of hospital, especially with the readmission, trying to meet the state's target. Because again, it's not just hospital readmission, it includes observation. So combining those two together for a large hospital system as ours, it really makes it very difficult, and with a target at 12.4. But we continue to work on it. We do have a daily readmission and throughput meeting, as well as an executive steering committee on readmission. Next is our quality dashboard. In addition to all of the programs, departments, and committee reports that we present, we also follow a lot of quality measures. About 34 of them spread across 7 domains that we track monthly. And these are those. Generally, we are doing very well. Our ED metric is a reflection of how busy we have been as an hospital. We have a lot of volumes, the highest volumes we have seen ever. But all other measures we're actually tracking in a positive direction. Next is the our QAPI plan, the quality committee presentations. As you know, with our QAPI plan, we do have departments, committees, and programs reporting to us on their metrics, so we can actually identify any gaps proactively and work at improving those. Since the last board meeting, we've had the Sound Hospitalist team, our nutritional services, antimicrobial stewardship program present, as well as our OB QAPI. And we also had a presentation about the CMS star rating program, which we have brought before this committee before. This will be an update, as well as sound anesthesia. With the Sound Hospitalist Group, they are the largest inpatient service by patient volume, and they provide round-the-clock inpatient care, and they help manage and coordinate across multiple specialties. They did share their quality metrics with us, and they are really doing well in terms of the patient experience, which is their first metric. They are achieving quite highly, and they continue to work with it and coordinate with the patient experience team. When looked at in terms of readmission by their service, they are also tracking well in terms of readmission to the Sound service. And looking at their throughput metric, which is really a priority for the organization in terms of transitions of care planning, they continue to do well as well. And we'll continue to work with them on this metric. And since they are really doing well with this metric, there's been a lot of ongoing conversation about really tightening up some of the performance around this metric, and also introducing new metrics that we'll be bringing back the next go around when we present their program.
Why do they have the 2 different discharge times goals? Why would you have both a noon and a 10 a.m.?
So it's discharge order and by 10 a.m. and patient actually leaving by noon. Yeah. Food and nutrition services, they actually enhance the hospital experience, and they really provide dietary needs to patient in a personalized way. Our patient with heart failure, low salt, our patient with diabetes, appropriate diet, and really that training and intervention for some of these diseases actually starts on the inpatient side as well. They also provide consultation for malnutrition on the inpatient side, and dietary consultation on the outpatient as well, as needed by our patient. This is really a a high-performing department. They continue to maintain their health department scores. This is available publicly, and they do very, very well with no citation, and they're exceeding all of their targets. In terms of late trace, they are also performances at target, and their inpatient consultation service, as I mentioned, is also really relied on a lot by our patient as well as practitioners across the institution. And the malnutrition consultation, which is really very important as well, especially for our patient population, is one of the things they also do, and they do those very well. The next program is the Antimicrobial Stewardship Program. This is a required program, both by the CMS and Joint Commission. As you all know, the antibiotic pipeline is really, really thinning out. The rate of antimicrobials getting approval has really declined significantly. So how we really manage these antibiotics, as well as preventing antimicrobial resistance, is really a cornerstone, both for the CDC, CMS, and Joint Commission, as well as an organization. This stewardship program really helps us achieve this. It's a multidisciplinary team. It has a medical director that is an infectious disease board certified physician, as well as infectious disease certified pharmacist and infection prevention specialist, with lab and nursing collaborating. One of the things they really do is to develop an antibiogram based on our local sensitivity that is specific to institution, and also help develop guidelines. It's one thing to have a national guideline that may not necessarily reflect our experience. So there's this ongoing monitoring and collaboration with our labs to ensure that we're actually tailoring our antibiotic therapy and regimen to specific local organism and sensitivity patterns. They do also monitor our standard antibiotic administration ratio. What that means is, based on all available data, there is a predicted amount of antimicrobial use that we should be. And that 0.913 number basically means we're using about 91% of predicted amount of antibiotic we should be using as an organization, which is really, really good. That is exactly where we want to be. We want to consistently remain below 1. And they are now moving it a step forward. We have hospital-based antibiogram, but we now have the capacity to go each department. ICU is different from regular ward. Surgical patients are different from medical patient. How do we drill down further with our antibiogram? That is the work they are doing now, and they do have preliminary data that they'll be discussing with the frontline staff to really equip all frontline practitioners in terms of antimicrobial selection and effective use of antibiotics. They are also required by the Joint Commission to develop 2 evidence-based guidelines for the organization. So for pneumonia, for example, is one of the guidelines, community-acquired pneumonia. What is our resistant pattern? What is the optimal antibiotic therapy, and what guidance do they want to provide for the organization? They have really done that, and they are developing more disease-specific evidence-based guidelines for the organization. OB-COAPI, this is maternal health, as we were successfully redesignated as a level 4 maternal facility without any contingencies. And this is through October 2028. This is really great news because, again, if you look at the performance of our OB team, and Dr. Kirsten Henderson is the chair of OB, and she's right here, they've really done a lot of work. And now, given the priority that CMS is actually assigning to this, as now maternal level of care and maternal performances and program is a condition of participation in, with Medicare now. We are way ahead of the curve, thanks to our OB team, in terms of that being a condition of participation in Medicare. And they do have a robust QAPI program, that's Quality Assessment and Performance Improvement Program, that actually all encompassing with the ED, with the ICU, with OB itself, and with neonatology. A high-performance group. I was the co-chair of the maternal cooperative program prior to assuming this role. So this is a program I'm very familiar with, and the numbers actually truly reflect impact on patient. Placenta accreta spectrum screening is, they do a fantastic job. The team does. As well as urgent request to the bedside within 30 minutes. This is really an overachieving metric on their part. The only requirement by regulation is to look at response to the bedside for specific diagnosis by specific providers. Those are 100%, both for our anesthesia provider and MFM providers, but they have gone further. They, as part of being a teaching institution, they are now trying to inculcate this into our residents. So that's why you see the number a little bit lower. That captures the resident data. They're just looking at everything. But for the essential critical component of this metric, they're 100%. The last time I brought this, the third metric to you, antibiotics on within 30 minutes, they were in the 40%. The requirement is within 1 hour. And they decided to actually, because they are basically doing 100% of hanging antibiotics within 1 hour for patient that needs it, they lowered it themselves to 30 minutes. And now they are knocking that off out of the park as well at 87%. Our cesarean section rate is something that we'll continue to work on. Again, our patient population really plays a role in that, as well as, but if you look at other safety net hospital across the state of Texas that will have data, we're pretty right smack right in the middle of the rate of cesarean section. Chorioamnionitis really ties to the third metric in terms of timely administration of antimicrobial agent. And we're at 4.2% with a target of less than 4%, and we continue to work on it. Dr. Carson Anderson just rolled out a program to actually decrease the number of examination, which is really been associated with increased choreo rate. So we do hope to start seeing some impact again to further lower the fifth metric.
So you were saying that this rate of C-sections were kind of average, but the Africa, requests is quite a lower number.
Yes, ma'am.
Is that achievable since we're doing what everybody else is doing? Is it possible to get lower?
Challenge is if they want treatment over self every year.
Mhm.
And at some point there is a threshold, but we try, we do our best to try to lower it, because we have long.
And Dr. Yeah.
And then you had mentioned that Medicaid is looking at kind of maternal health. Is there a time period? It's perinatal, but is it like a year after birth? Is it 2 years? Is that Dr. Carson Henderson might be able to answer this. Is there a time period they're looking at maternal health postpartum?
I think it's still a little bit up in the air. The minimum goal should be a year after delivery. We always think of 6 weeks postpartum, but the reality is that recovery and stabilization of condition.
No, absolutely. You're absolutely correct. I think they're still looking at it. They've not given a formal announcement in terms of where they will land and what their requirements will be.
Because I know that just as a county, we've been working hard with postpartum maternal health.
Yes.
So it would be really great to, I don't know if that belongs in this type of quality, but like to kind of look at that data and make sure we're following mothers postpartum, figure out what that time period is. So.
Absolutely. Sound anesthesia. This the anesthesia group that support our surgeons, and they really ensure the OR runs efficiently and in terms of utilization and start, as well as patient comfort, which is really the primary role of anesthesia. In terms of patient experience, they actually carry 2 patient experience metrics that really is specific to anesthesia, and they are doing very well with those. And one of the measures we monitor closely is anesthesia-related unplanned transfer or admission from an ambulatory surgical center. And that is really below below the target, which is a good thing. And again, the KPI 5 is really anesthesia time out to ready speaks to efficiency. If the patient is in the OR, are we getting started immediately? And looking at, again, response, as I mentioned earlier in the earlier metric, in terms of being responsive and being there for laboring mothers within 30 minutes, they are 100%. We continue to work with our anesthesia group, and we've proposed a few other metrics that we are working on, especially the anesthesia post-operative respiratory failure. We really do want them to carry those measures, and they're really very excited about that. We've had a couple of meetings with that. So again, this is one of those KPIs that will also change a little bit next time we bring this back to you. Now, CMS star rating, from time to time, we do bring to you programs, Leapfrog, CMS, and value-based purchasing. This is CMS star rating. How do those external lens look at JPS? How are we rated as an organization? It's really one thing to present all of our data, but we also feel it's important to look at external reporting data. How are we seeing? One of the more comprehensive, actually the most comprehensive external quality review is the CMS star rating, and they evaluate organizations such as ours across 6 domains. It used to be 5, they're expanding it to 6: mortality, readmission, safety of care, patient experience, timely and effective care, and of course now patient-reported outcomes and performance measures. So some of these measures are most likely familiar to you because we also follow them in addition to others that CMS follows specifically. Based on these measures, they really organize organizations into buckets, into 2-star, 3-star, 4 stars. This is the JPS journey. We've made a lot of improvement. We continue to work hard at it. But now in 2025, JPS is a 4-star by CMS, just based off of.
Great job.
That was announced in July. Yes, July. Yes,
Great job.
yes. So
It's not
we
easy
can.
to do.
Pardon me?
So it's not easy to do.
No, it is not. And we continue, again, this is really a lot of teamwork, and we'll continue to work at it to really sustain it, because really putting in those processes, as Dr. Duncan reminds me always, you gotta hardwire it. It cannot be one-offs. So really, all of the improvement efforts that we've been putting in place, really, we are trying to hardwire it so that the variability will reduce and the upward trajectory will be sustained. And that's really what we're going for. So we'll continue to work at it. Dr. Holland, that's all I have for this month, but I will take any questions.
Do y'all have any plans in the future? I mean, just you can highlight to continue to work on the CMS. I know we're already working on so many of these 6 pods of rating, but is there kind of a plan of continuing to move forward?
Absolutely, absolutely. We are especially focused on the patient experience portion of it. We do have a lot of opportunity, and patient safety. Patient safety is another big bucket that we'll continue to work on, and especially because the way CMS looks at it does not really allow for a lot of flexibility. They look at administrative claims data primarily. So we really have to focus on that and really translate those to meaningful improvements in our patient. The overall strategy that we have decided to take on is, while CMS looks at traditional Medicare patient, we look at every patient. We expand all of our improvement efforts to every patient across the network. CMS can extract their data. We analyze it to look at it, but the data we present on our dashboard is not just CMS patient, it's every patient. So that any improvement effort we initiate is meant to affect all of our patients.
I love that. Do we have any questions? Thank you so much, Dr.
Thank you.
Dr. Casey? Are we going to close?
Yeah, we're going to
or
go
is-
close.
Are we going to close first?
Okay.
Okay, so we will close the open. Do we need to Dr. Casey?
I thought he was just gonna do an overview. I thought it was over. No, she's asking you, is this enclosed?
Do we need to discuss, this isn't open?
This
Okay.
is an open.
Okay, so we are not closing it. Sorry.
Yeah. Do we have his slides?
We'll do the action item.
So those who have been on the quality committee for a while, this was not previously part, Dr. Casey has asked that we add credentialing and privileging at JPS to the quality committee. This previously just went directly to the board, and he can explain his why.
The last four.
Don't click.
It's not loaded on the screen. Do you need the slides, Dr. Casey, so you can present? I think they have it on their iPads, but not the screen.
I would like.
Sure. Okay.
Thank you.
We're still in open.
Yeah, we're still in open. We are not closed yet.
Yes, thank you, Dr. Holland and fellow members of the Quality Committee. I've sat in this chair 20 years ago, and we used to present a few more things to the Quality Committee, and when I rejoined 18 months ago plus, giving you the credentialing and privileging and the open board just as never left a great feeling. So I wanted to at least have a run back to the Quality Committee for some notion of more transparency of our processes, perhaps more dialogue back and forth. And so this is kind of our first run, at least part of that. And I also want to give a little bit of a 50,000-foot view of what credentialing and privileging is as an vital function of the medical staff to make a recommendation to the board. And so in your packet, you'll see slide 1 on page 43 of credentialing and privileging is two separate terms. And what are they distinguishing? Well, yeah, it's peanut butter and jelly. You need both together. But credentialing does verify a clinician's education or training or experience, and to be certain that only qualified, competent folks practice at JPS. And those requirements are set by many different organizations. Dr. Batamosi mentioned a few, but some are Texas law, CMS, and obviously the Joint Commission. And then privileging is the notion, and those are the things that we talk about when we get to, and later in the agenda of delineation of privileges. Those are the particular items that someone can perform while under in the organization, from performing an H&P to prescribing an antibiotic to conducting a surgery or any other procedure. And it is the obligation of the medical staff to make those recommendations to the board as to the scope and the amount of that. And all of that's consideration on basis of training, on their education, importance of their continued experience in those domains. And those things also have to be looked at regularly. And those are the things we've been bringing when we do the quote DOPs and will later. They have to be reviewed again over time because I think it's important to see as technology moves, some of that might change a little bit as other specialties grow and other things of that sort. A quick review of the process is on page 44. And I think that perhaps, and I would volunteer for an overview to present at one point of what the medical staff is, if that would be accepted.
Mm-hmm.
But yeah, it's an application first. And who submits that application? Well, historically, the individual, but now more and more that's in conjunction with the patient, with the doctor's physician group or the clinician's group. That goes to the medical staff office, and they begin their job. Primary source verification is an extensive background check of all the things aforementioned and other things. And that goes to the department chair who does a review, sends that to our credentials committee, sends that as a recommendation to the medical executive committee, and then that sends it to you as a board for final approval of that. And along the way, there can be back and forth. You may have witnessed that over the last couple of years where we've sent things back for reconsideration on and on.
That's typically what we would get in our red folder, right? Is a list of.
So historically in the Red Forum Monthly, as it relates to timelines, we do the list of the individuals, and then periodically we do the list of the privileges, which we'll do today. Historically, we have talked about, and we have done in the past, where all the individuals would come to the Quality Committee monthly, when this meeting was monthly, to discuss each individuals, but we haven't done that in several years, I understand. Last time I sat in this chair, we didn't talk about APPs, that is nurse practitioners, physician assistants, CRNAs. It was only about physicians, and that does so much gray hair I've got since that time. And so that has grown. And so a list of distinctions of what their licensing, training, supervision, and privileges is important to take note of. And that's on page 45 of your list. So physicians to TMB, clearly their medical school residency, fellowship, and their board certifications that they maintain. They are of independent practice. And then full privileges are based on their specialty training and their experience. And the APPs have the Texas Board of Nursing, and we've had a few of those cases we've talked about. But they also, more importantly, in supervision, they have to have a physician with a delegated agreement that's going to be their supervisor, and anything they do is under that physician. Maintain accuracy, safety, and compliance. So these lists that we bring to you, some of them are new, some of them have been generated, some have been reformatted, but oftentimes there are a refinement that has been looked at again at the department level, at the department chairman level, again at the credentials committee, the med exec. As I mentioned, things change as time goes on. So it's a healthy organization that continues to look at both the individual and those privilege forms to be sure clinical practice is being made, but also weighing and balancing the needs of the institution, what's happening in the community, and on and on. And so that's just a brief, quick overview. Later, we do have some catch up, and I do apologize. We have so many this month for approval to go through. We can talk about some of those individually, I guess, when we get out of closed.
So, Dr. Casey, with your new proposed process, would this committee approve it and then the board also approve it, but with less detail provided, or?
I think Dr. Holland's idea would be perhaps on consent agenda, which is what historically, and I do mean now decades, used to be the way we go,
So,
where we
yes.
would do a deep dive here.
Consent item.
Yeah, as a consent.
So we wouldn't get list of names at the board.
I think it's your discretion how you'd want to do that going
Yeah, it would
forward.
still be available for you. The list of names would be available, but the details would be discussed.
More details here, more transparency.
I feel like we're doing the equivalent of consent agenda
Right now.
currently without the pre-discussion I think we share that concern because we get a list in the board and we look at it, but there's not a discussion around the list.
So are you thinking there might be some discussion here at committee?
Yeah, and I think it would be what the med exec committee feels needs to be discussed.
It's my personal preference that we have a little more availability, at least for discussion,
Okay, good.
than current status.
Because we don't do a lot of talking at the board meeting on this.
We don't.
For
You
a
don't,
number of reasons.
yeah, you don't really have numbers
time.
that are actually coming through the filter that never get actually presented. So just to have some metrics, yeah.
It's my preference. Now I have a few more months to be my recommendation, but for your deliberation.
And some of those things would be handled in closed session, I guess.
I think it offers more opportunity to have more discussion about.
If it's at detail level,
Mhm,
yes.
I
absolutely.
think if it's an individual,
Individual, yeah,
Yeah.
closed.
it's required.
Privileges. So when we get the privileges, who's drafting the privileges? Is it the departments or is it the med executive committee who is drafting the privileges? How is it getting to our plate when we get the
That's
final?
yes. And then our credentialing office, in our audience is Adam Pritchard, who's after Dr. Duncan and Daphne is the most talented person at JPS.
Heard really good things about that.
I think he's
as it
above
relates
us.
to- And why I say that more than anything is I have watched the professionalization of credentialing and privileging over the last 20 years to this extraordinarily high level of detail and things that I didn't notice 20 years ago when we were just doing lots of phone calls to back things up. And so Adam's office is amazing. So to your answer, they are seeing what community standard is, what regulations are, and then we're making a lot of decisions on that with a lot of discussions.
We else have any questions about credentialing and privileging? Okay. Do you want to go ahead and just delve into the privileges that we're looking at?
Yeah, I think in the packet, I've been asked last night to pull number 1, so we have 11 then to prove. And again, I apologize, some are left over. It could have been perhaps done in July, but
I know it's asking a whole lot of you, Dr. Casey, and maybe we can get some, also some.
So on page 4.
insight. Is there any major changes
No.
previous that you would want to point out to us?
On page 48 is, I think, I understand the board's requested a summary page. It's a little longer than I hope to do in the future. But from page 48 to 54, I think, is a summary of all the changes. And there's no, some of the forms are new. As in your packet, you may see some red lines in ones and not in the others. Those forms are new. The red lines, I don't think any substantive big discussion item changes. Again, we want to, I was asked last night to pull number 1 on the agenda, so it'll be 2 through 11 for approval to send to the full board.
And so one is just the advanced
Yeah.
practice provider of hospital medicine.
Yeah.
That one's tabled.
Table that one, please. Yeah, thank you.
Okay. All right. Does anybody have any question about the privileges? Is there, other than the number 1?
We're tabling the APP hospital. That's the only one.
Yeah, that's
Correct.
Is there anywhere that we limit the scope of practice above what the state of Texas allows for?
I think all areas may not be exactly congruent to what state allows on the basis of us having capability in certain areas and other specialties. So yeah, I think that's fair to say. Generally, that's fair to say. So what may be allowed in West Texas, an under-resourced area by a certain group, may not be here. Yeah. That's our duty to make those jump. That's some of the discussion that I do think, in my personal recommendation, the board understand why someone in some specialty is doing something on the basis of need. Obviously, Dr. Batamosi is measuring the quality, and so we feel very good about that. But I think that helps make a lot of decisions. Yeah.
So for all these areas, especially the state sets maximum privileges?
I think it's a fair state. Other organizations, I would say, is more fair. Yeah. That's right. That's right.
It's not always the state.
Not just the state. Yeah, I would. Yeah. Special organizations, training, may cap it. Yeah.
But somebody sets a maximum list of privileges
That would be expected. Yeah.
for any specialty.
Yeah. And then
You
it's,
can't exceed that maximum, whoever sets that.
and it's the med staff's job to recommend to you that that's
Scope of
correct.
practice.
Yeah, that's right. Scope of practice is the way. Yeah. Thank you.
Do I need to make a motion? So
Yeah, somebody.
I would like to make a motion. Do I make a
Or
motion?
you can ask somebody. to
Can I
make a
ask
motion.
for someone to make a motion to approve the delineation of privileges minus number 1?
Yeah,
So number
items
2 through
2 through 12.
12 on our list here.
I move to approve the delineation of privileges minus item 1 for hospital medicine.
I'll second.
Okay. And all in favor? Any opposed? Thank you.
Thank you.
All right, now we will move to closed.